And the slides are visible,
Okay.
make it full screen.
Are the slides visible?
Yes,
Is that
yes.
okay?
Yes, it's
Okay.
visible.
So thank you, organizers, especially Ashok sir, Alok sir, Kanwar sir, Jayashree ma'am, and Sambit. And kind words from Dr. Chandan Das. Actually, there was last minute changes, and I was to speak on cognition, but we have an entire session on cognition. So I'll be touching on painful diabetic peripheral neuropathy. So this is also an interesting area and gray area. Most of you must be seeing a lot of cases of painful diabetic peripheral neuropathy. So, with more than 100 million people with painful diabetic peripheral neuropathy, and 50% of the diabetics developing painful diabetic peripheral neuropathy over 5 or 10 years, the data for management is not very robust. Let me be very specific. As we all know that diabetic peripheral neuropathy, what we commonly see in our clinics is a symmetric length dependent sensory motor polyneuropathy. This is the most common type, that is the DSSN. But we also see cases of distal symmetric sensory motor polyneuropathy apart from the sensory ones. So these two are the most common, and among the DSSN group, the painful neuropathy occupies a major chunk. At least 50% of cases you see in your clinics of diabetic neuropathy belong to the painful sensory neuropathy group. Not breaching more on the pathophysiology, as you all know, it's an axonopathy due to small vessel vasculopathy. And the pain starts after damage to the small fibers, especially the C fibers. But as time progresses, there's a central mechanism which comes into play. So most of us, as already Dr. Chandan has pointed out, that it's the traffic of the energy into the axons which is halted, be it derangement of mitochondrial production, dysfunction, ATP loss, and it's a distal to proximal degeneration which follows a time-bound phenomenon which leads to the pathophysiology of painful diabetic peripheral neuropathy. Already, we are discussing this, we have discussed obesity, insulin resistance, but a lot of factors play a major role in shaping diabetic neuropathy as it occurs in the patients. We see hyperglycemia as the root cause, but is it the only cause? No. There are other causes, including dyslipidemia, energy overload, bioenergetic failure. All this need to be taken into account when we are harboring on treating a patient with diabetic neuropathy. So basically, we have two groups of symptoms: those which emanate from the large myelinated nerve fibers and the small nerve fibers. Basically, what we see commonly are symptoms from the small nerve fibers, which include some positive phenomenon and some negative phenomenon. The positive ones are the burning, electric shocks, stabbing, hyperalgesia, and allodynia. The negative symptoms are numbness and cold or soreness. If the large fibers are sequentially involved, then we have poor balance, ataxia, and we have defective vibration and pressure sense. So all this, if you have any symptoms relating to these two types of fibers, you can very well do a focused clinical examination. All of you are busy practitioners in your day-to-day practice, so at least spend 2 to 3 minutes for a neurologic examination. 1 minute for the symptoms, 1 to 2 minutes for the examination, clinical diagnosis. Basically, these are some of the catch symptoms which you should ask your patients to report if they have a burning, electric shock like, tingling sensation, allodynia, numbness, or a cold soreness. So once these patients present to you, your approach should be a stepwise approach, a targeted history. Try to get the detail of the duration of diabetes, the age group of the patient, any metabolic syndrome, and any social determinants. Also ask about the type of pain, what kind of pain, because that is also a catch. If you have a small fiber neuropathy, you may have burning pain or pricking pain in the feet or hands. And if it's a lancinating or shooting pain, you may well be looking at the radicals or the plexus. Whether it's worse at night, and any symptoms of numbness, poor balance, or weakness. A focused clinical examination, which we will touch upon later. But what is the time when you treat a patient and when you refer to a neurologist? If the symptoms and signs are symmetric, length dependent, glove and stocking pattern, it's a simple distal symmetric sensory or sensory motor neuropathy, very well you treat the patient. But if there are red flags like asymmetry, predominant motor involvement, and if the symptoms are progressing at a fulminant pace, then do refer to a neurologist. One of the important points which we occasionally miss while diagnosing diabetics with peripheral neuropathy is the differentials. If we don't consider other disorders, and even in a diabetic, we may have other diseases which increase the coexistent neuropathy or which require treatment prior to treatment of the diabetic neuropathy. So these are some metabolic diseases, infections, nutritional deficiency. Many studies have shown B12 deficiency and thiamine to be the causes of non-response to drugs or resistance to drugs. CIDP is a great masquerader. Also inquire about drugs, especially alcohol, chemotherapy, and heavy metals, apart from genetic disorders. There are a lot of assessment scales, but I won't go into the details of assessment scales. Most commonly used is the Michigan, and in India, we used a revised neuropathy disability scale. But for general practitioners in a busy clinic, you can rely on the VAS and the NPRS. These are simple pain scales where you ask the patient about the subjective pain, starting from mild, moderate to severe. 1 to 3 is mild, 4 to 6 is moderate, and 7 to 10 is severe. So this is just a screening rating about the severity of pain. Apart from that, you can spend 1 minute in doing a sensory neuropathy examination, especially for small fibers. You use a monofilament or a pin. And you can use a 128 Hertz tuning fork for the large fibers. There are a lot of tests, but just need to highlight that if you are suspecting a neuropathy, and you see that the patient is not amenable to treatment, do refer to a neurologist, get a nerve conduction study done. Nerve conduction gives first-hand information about the status of the motor, sensory, but what it misses are the small fibers and the autonomic nerves. So if you want a detailed examination, you can do a sympathetic skin response, QS-ART. So these are simple things which can be done in the neuroclinics. And if you are referring to an ophthalmologist, do get a corneal confocal microscopy, which has a very high sensitivity in the tune of 85 to 86% in most studies. Apart from that, newer techniques like magnetic resonance neurography and nerve ultrasound and the intraepidermal nerve fiber density estimation are newer modalities for diagnosing these small fiber neuropathies. The goal has to be individualized, especially when you see that there are variations in the various guidelines provided. But all these guidelines had one goal common, that was reduction in pain to the tune of 30 to 50%. That would lead to improvement in daily functioning. There are other questionnaires which ask for quality of life, sleep, and mood. So a 30 to 50% reduction is the initial goal. Do not be over-aggressive and treat till the patient has nil pain. It is very, very difficult to achieve.
Dr. Soumya, we have another 5 minutes left actually.
Okay, we'll go straight into, risk factor reduction. I won't go into the details, but that is important as much as lifestyle modification and non-pharmacologic treatment can be used, especially in resistant cases, including TENS, FREMS, and the spinal cord stimulation. What we will discuss is what the guidelines have to say regarding management of painful neuropathy. So most guidelines have a consensus regarding the tricyclic antidepressants, gabapentinoids, and the SNRIs. But of late, ARN is the only guideline which has given first-line recommendation to newer antiepileptics like oxcarbazepine, lamotrigine, lacosamide, and even valproate. Again, the dual mechanisms, opioids, tramadol, propentadol, are recommended as third-line medications for diabetic painful neuropathy. Tricyclics, SNRIs, gabapentinoids are always first line in the treatment. So this is a simple algorithm where you have all the neuropathies, but if you see that the painful neuropathy, you have to have gabapentinoids, anxiolytics, including tricyclics, SNRIs, and if they don't respond, go to the third line or second line treatment. So in a nutshell, these are the first line which we all use: pregabalin, gabapentin, amitriptyline, nortriptyline, and duloxetine. Among the SNRIs, which are second line, are Velna and Desvelna, Tramad, propentadol, and the patches. Third line are the newer group of drugs. So basically, we start with a monotherapy, especially it's either pregabalin or gabapentin. And if the response is not adequate, we add a tricyclic or an SNRI. We'll go to the combination therapy in the next slide. And if the patient has partial effect, now you have to give adequate time for titration, at least 2 to 4 weeks, and you have to look if there is inadequate pain control. This is the time you switch to alternative or go for a combination therapy. So basically, there are two studies which I want to highlight. One is the study which was done by the group of the Danish group. And especially this study was the combo TM study, where the maximum monotherapy versus the standard dose combination were found to be equally effective. The next study is an option DM study, which was validated for combination therapy in where monotherapy was suboptimal. Now, you can add 2 to 3 agents, but in real world, we see that there is not much difference if you add pregabalin with a nortriptyline and a methylcobalamin versus a gabapentinoid drug. This was published from the Indian data in December 2023, where they found that pregabalin is slightly more effective, but safety-wise, both pregabalin and gabapentin have similar side effect profile. How long do you treat? You need at least 4 to 6 weeks for titration, and the maximum duration of a drug can be from 4 to 6 months. In cases where there is refractory painful neuropathy, you refer to pain specialists, and these are the recommendations: lidocaine, botulinum toxin, spinal cord stimulation, and some newer drugs like zibenotide and tanezumab. So this is the IASP's specific pain group, special group, which has the first, second, and third line recommendations. I won't go into the details of the antidepressants, but duloxetine versus nortriptyline, if you see that you have to weigh the side effect profile, and duloxetine has a better side effect profile compared to nortriptyline. That is the reason for combination, newer combinations with pregabalin. Head-to-head, pregabalin versus gabapentin. Pregabalin is the FDA-approved drug, and it has better efficacy. But side effect profile, gabapentin is the better drug. But the need to titration, you can titrate pregabalin very early, while gabapentin is erratic in titration. But given the side effects, edema is lesser with gabapentin, there is lesser sedation, and also the addiction to gabapentin is lower. Opioids have limited efficacy, so the newer kids on the block are cannabinoids, lamotrigine, topiramate, zonisamide, and lacosamide. These are the new antiepileptics, but they don't have an FDA recommendation. We need to see how they come up in the future, but we can use them for resistant cases. So summarizing, it is a very common symptom and the patient requires pain relief. Treatment has to be individualized. You have to be very cautious, especially if patient has comorbidities, it's an elderly, or a patient has renal impairment, especially when, or cardiac impairment, especially when you are using tricyclics, or even you are using pregabalin or gabapentin in renal patients. Important that you go for a start with a single drug, preferably pregabalin or gabapentin, add on combination if you have a suboptimal response. Third line drugs are required if the patient is not responding, but it is better you refer to a pain specialist. Neurologist help comes when you have atypical symptoms or signs. And in cases where there are radicular pain, or cauda equina involved, then you can use combinations.
Dr.
And
Soumya, it's time.
mirogabalin
Please
is
wrap up in 1 minute.
Yeah. Yes, sir. It's over from my side. Nutraceuticals do have a role. And summarizing, you not only have drugs which are the mainstay for symptomatic treatment, you have to have a combination when there is suboptimal response. Non-pharmacologic behavior has to be taken, and risk factors have to be ameliorated. So thank you all for your patience.